Dr. Dinesh, thank you very much for those kind introductions. I'm going to be talking to you about integrating oral semaglutide in the type 2 diabetes treatment landscape, particularly the benefits of early initiation. These are my disclosures. So the next few minutes, I'll take you to the background of type 2 diabetes and barriers to glucose-lowering therapies, then overview of GLP-1 receptor agonists, and then particularly home in on oral GLP-1 receptor agonists, a really exciting area that we've now got in our armament, and then summarize. And so as background, we have had a number of therapies for many years. But as you can see, these are really great data published in the New England Journal of Medicine that we don't seem to be achieving the targets. So the top left-hand side, we can see glycemic control has remained pretty steady between 1919 and 2018. These are data from the US, but we see similar data from around the world, and we've published similar data in the UK as well. Blood pressure targets have improved over time, but again, now they're stagnant. Lipid control has improved, achieving about 55% now. But if we look at all three targets, which are very important, we're achieving all three targets for about 22% of the population, which just really isn't good enough. This is our Discover study, which is a 37-country prospective study with over 15,000 participants. And here we're looking at the choice of second-line glucose-lowering therapy in people with type 2 diabetes. And you can see choice of second-line therapy is usually on top of metformin therapy. It's metformin and a sulfonylurea, metformin and a DPP-4 inhibitor. The proportion of patients who are being prescribed the newer novel therapies where we know the evidence base is really strong for is low. For example, SGLT2 inhibitors with metformin 4.3%, metformin and GLP-1 receptor agonists about 1.3%. And the mean HbA1c at initiation of second-line therapy was 8.3%. Again, despite all the amazing results that we've got of early glycemic control, we're waiting far too long. This is a bit more detailed data from that study, broken down into the various regions in the world. And as you can see, overall, the age of the participants was anything from 57 to 60 years. HbA1c varied from 7.9% in some countries to around 8.6%. But look at the bottom two results. These patients already had microvascular complications, about 18% had them, and 14% had macrovascular complications. So we've got to really go in early because these patients have already had micro and macrovascular complications. Now, these are patients who had been assessed for micro and macrovascular complications. There will be many who haven't been assessed, but they do have underlying macro and microvascular complications. So what are the main reasons that we're not achieving targets for these patients? Well, we can break them down into a few reasons. Key reasons are complexity. Type 2 diabetes management is becoming very complex. We've got so many different therapies. We've got so many things to think about. And remember, patients with diabetes don't have just diabetes. They have other multiple long-term conditions. So we have to put that into balance as well. There's fear of injections. We know that's been there for years. And no matter how good our advances get on the needle, we will still get the needle phobias. Patients and healthcare professionals both alike worry about hypoglycemia and obviously the issue of poor adherence. Let's look at insulin, for example. These are a couple of data. One is a multinational study on the left-hand side, and we see in terms of treatment adherence to insulin therapy, about 33% are poorly adherent. Data on the right-hand side from the UK, again, about 30% are non-adherent. But this is a really nice slide. This is looking at what we call efficacy to effectiveness gap in management of diabetes. So in this study, what they looked at was GLP-1 receptor agonists in a trial setting. We were seeing about a 1% reduction in HbA1c. And they assessed HbA1c reduction in the real world setting, and it was about 0.52%. So this 0.52% difference is called the efficacy to effectiveness gap. And By modeling, they assessed that about 75% of this efficacy to effectiveness gap is due to adherence and 25% because the baseline characteristics between the trial participants and the real world participants were different. So overall, we're not achieving the targets that we're supposed to with the therapies with proven benefits. In this study, they also showed that GLP-1 receptor agonist adherence rate in the real world was only about 30%. But this is mainly assessed by looking at the proportion of people who had their prescriptions dispensed. We've now got new ways of assessing adherence, and this is through objective measures. And this is something that my two friends in Leicester, Pankaj Gupta and Prashant Patel, have developed. And this was the first study looking at an objective measure of treatment adherence. So we collected in this study routine urine samples when patients came for the annual review, and adherence was assessed by LCMS method. And in this study, we found that 28% of people were non-adherent to oral hypoglycemic agents, antihypertensive agents, and lipid-lowering therapy. And non-adherence to statins was the highest, about 23% were non-adherent. And for oral hypoglycemic agents, it was about 4%. And this study did show that people who were non-adherent, they had worse HbA1c, albumin-creatinine ratio, and lipid profiles. Now, let's come to GLP-1 receptor agonist. We know that in terms of development of type 2 diabetes, this is quite complex. There are a number of pathophysiological mechanisms putting people at risk. This includes impaired secretion of insulin, insulin resistance, increased hepatic glucose production, impaired appetite regulation, decreased glucose uptake, increased glucagon secretion, decreased incretin effects, increased lipolysis, and increased glucose reabsorption. So we need to have a multifactorial approach to management of people with type 2 diabetes and to prevent the complications. And we have excellent guidelines and consensus reports. For example, the ADA recommends that most people with diabetes should achieve the following targets: HbA1c less than 7%, physical activity, we should be encouraging our patients to have about 150 minutes of physical activity per week. We should be aiming for a blood pressure of 140/90, triglycerides below 1.7, HDL of 1.3 for women and about 1 for men. And we try and go for cholesterol, total cholesterol of below 4 as well. So management of diabetes and complications includes tight glycemic control, lifestyle modification, tight blood pressure control, and tight lipid control. GLP-1 receptor agonists have multifactorial effects beyond glycemic control, and that's why we really recommend these because they have a number of pathways they target. So in terms of pancreas, there's improved beta cell function, reduced beta cell death, improved insulin production, and reduced glucagon secretion. There's also effects on the heart with improved cardiovascular risk, fatty acid metabolism, cardiac functions improved, systolic blood pressure is reduced, inflammation is reduced, and there is reduction in plaque progression. And a huge benefit in terms of weight loss, either through reduced appetite and reduced food intake, and also incretin-based system in terms of replacement of deficient GLP-1 response. So overall, we do get multiple effects of GLP-1 receptor agonists for insulin, for glucose, carbohydrate to fat production, accumulation of lipids, and retention of lipids as well. In terms of the number of GLP-1 receptor agonists, we can break them down into the original ones that first came out, extendin-based therapies, and now the human GLP-1 receptor-based therapies. As you can see on the left-hand side, the human GLP-1 receptor analogs, they have over 90% homologous to the original extendin-based GLP-1 receptor agonist. And we've moved at a pace in terms of the number and the types of GLP-1 receptor agonists that have been produced. So we initially had the once or twice daily one, exenatide and lixisenatide, and then since then we've had the once weekly ones, the exenatide extended release. We've got liraglutide, dulaglutide and semaglutide. And if we look at the systematic review of GLP-1 receptor agonists in terms of cardiovascular outcome trials, this is looking at 3-point MACE outcomes, cardiovascular events, myocardial infarction, non-fatal myocardial infarction, non-fatal stroke, or cardiovascular mortality. We see there's about a 14% relative risk reduction for this in favor of GLP-1 receptor agonists. So a huge amount of evidence that they do reduce MACE outcomes. The ADA ESD consensus report and ADA guidelines, all of them are giving us now evidence-based guideline recommendations in terms of glucose-lowering medications. As we can see on the left-hand side, that's where we have the good quality evidence. And I'll just take you a little bit into a bit more detail here. And what we say here is that people who have established atherosclerotic cardiovascular disease or at very high risk, or people who have heart failure or CKD, we need to be considering the novel therapies of a GLP-1 receptor agonist or SGLT2 inhibitor. And when we're not getting to glycemic control, we should be considering the other therapy that wasn't used in the first place, either a GLP-1 receptor agonist or an SGLT2 inhibitor. The European Society of Cardiology guidelines have gone one further on diabetes, pre-diabetes and cardiovascular disease risk. And they are recommending that if people have atherosclerotic cardiovascular disease or at high cardiovascular risk, then we really shouldn't be thinking about metformin, while the ADA suggests that we should be doing metformin and then adding the novel therapies. Here they're saying we should be going for an SGLT2 inhibitor or GLP-1 receptor agonist monotherapy. If HbA1c is above target, then we should consider putting metformin. Otherwise, if they don't have atherosclerotic cardiovascular disease or they're not very high risk, then we should consider metformin therapy. And if the HbA1c is above target, then we start using any of the therapies that we currently have in our armament. But these are quite contentious because metformin has been there for many, many years, and every guideline suggests metformin, but cardiologists have, as I said, gone one further and suggested that we really should be going for these evidence-based therapies first line if people have high risk. So now coming to oral GLP-1 receptor agonists, and we'll just come to the molecular structure. We see semaglutide there, the first oral GLP-1 receptor agonist. And this again is very homologous to the native GLP-1. And the reason we now have an oral GLP-1 is because there is absorption issues with just using oral semaglutide. But this has now been enhanced with co-formulation of SNAC. And what SNAC does, it increases the local pH, leading to high solubility and protection from degradation, which would normally occur for a GLP-1 receptor agonist that's ingested. In terms of how to start oral GLP-1 semaglutide is that we have a starting dose of 3 milligrams. You use that daily for a month, and then we increase to 7 milligrams for the next month. And when tolerated, we would go to 14 milligrams a month later. But there's one important thing regarding how to take semaglutide orally. We need to take that in an empty stomach on waking or any time of the day. But it needs to be taken with a sip of water around 120 mils or less. But then we need to wait 30 minutes before eating, drinking, or taking other oral medications. There are other things we need to consider. We shouldn't really be splitting the tablets, crushing them, or chewing them. They should be swallowed. Taking 2 7-milligram tablets may not achieve what's achieved with 14 milligrams because this hasn't been studied. But the most important thing is about the waiting 30 minutes, because if we don't wait 30 minutes, then absorption is lower. The good thing about oral GLP-1 receptor agonists is that there isn't much to think about. I said to you right at the beginning, one of the reasons we don't get therapies into our patients is because of the complexity. We have to think about so many things. We need to think about liver function tests. We need to think about EGFR. We need to think about age. We need to think about how old the patient is. Are they at risk of hypoglycemia? Well, with oral semaglutide, we know that there's no dose adjustments. for mild, moderate, or severe renal impairment. And the experience with use with oral semaglutide in severe renal impairment is limited, but we can go down to an eGFR of 15. In elderly, we don't need any dose adjustments, but we don't have much experience in people over 75 years of age. But there isn't any reason why I shouldn't be using, if appropriate, to do so in this age group. And again, with hepatic impairment, we have no dosage adjustments required at all. And most of this evidence base is based on solid randomized control trial evidence, the so-called PIONEER program. And PIONEER has had a number of trials, particularly looking at early glycemic control. So initially it was with placebo, people who were diagnosed with diabetes, with diet and exercise, and then with oral hypoglycemic agents with SGLT2 inhibitors compared to DPP4 inhibitors, compared to GLP-1 receptor agonists, liraglutide 1.8 milligram. And then there was some flexible dosing adjustment, but that's something that we're really not recommending. And then later on in insulin users and more severe patients with renal impairment, and CV safety obviously has been tried as well. Let's look at the results with oral semaglutide. And I'm just going to give you an overview of the PIONEER program, PIONEER 1, 2, 3, 4, 5, 7, and 8. And what we see here is reductions in the HbA1c, and these trials were anything from 26 to 52 weeks. And you can see the superiority of oral semaglutide in terms of HbA1c reductions. We're getting HbA1c reductions of 1.2 to 1.4%, which is quite remarkable for an oral medication. And as I said, this is against oral therapies and even against liraglutide 1.8 milligrams. So really good efficacy in terms of HbA1c reductions. The other good thing is that HbA1c reductions were maintained when these patients were followed up. So again, we have trial programs with monotherapy at 26 weeks, but against a DPP4 inhibitor, sitagliptin, up to 78 weeks. And all the way through, we see that superiority is overall maintained with the high-dose oral semaglutide. Proportion reaching a target of less than 7%, an important landmark when we're managing people with type 2 diabetes. And again, we see 77% on monotherapy achieving this target at 26 weeks. But overall, anything from 54 to 77% of people are achieving a target of 7%, which is again quite remarkable. Weight loss, again, change in body weight, huge reductions in body weight, all superior with oral semaglutide. We're getting weight reductions from anything from 3.4 to 4.4 kilograms, and this is with a higher dose of oral semaglutide. And this is, as you can see, comparing against all the other oral therapies, including with the placebo as well. And change in body weight at the end of treatment, again looking at longer term maintenance weight loss. As you can see, longer term is very difficult to maintain weight loss if you look at the weight loss trial. But in this study, as you can see, even up to 78 weeks, we're seeing a 3.2 kilogram reduction in weight. And at 52 weeks, anything from 3.8 to 4.3 kilograms in weight loss, which is maintained over time. With all of these trials, we see the higher the weight, the greater the reduction in weight we will see. So it's really worth considering in people who are obese. When we look at the incidence of adverse events with oral semaglutide, and we look at it by comparators, there isn't much of a difference. Even when we look at placebo, some of the trials, placebo is 56%, which is exactly the same as what you see in PIONEER 1 with the semaglutide doses as well. Similarly, across all the trials, there isn't much of a difference between either placebo or active comparators in terms of incidence of adverse events. Now, I'd just like to talk to you briefly about PIONEER 6, which was a safety trial, a non-inferiority trial. 3,183 participants were enrolled, either going on to 14 milligrams of oral semaglutide with standard of care or placebo and standard of care. And this was an event-driven trial with 122 first MACE events. And as I said, safety trial, non-inferiority trial was planned, and we see that hazard ratio were 0.79, 21% non-significant reduction in primary endpoint of the first MACE events. And this met its non-inferiority margins, but it wasn't significant for superiority. But remember, this was a safety trial, event-driven trial, only 76 events in the intervention arm, 61 events in the placebo arm. However, some interesting results came through in terms of the components of the primary endpoint. These were pre-specified. Cardiovascular death, 51% relative risk reduction, which was quite remarkable, although the number of events was low, 30 events in the placebo arm, 15 in the intervention arm, but still quite a remarkable result. First non-fatal myocardial infarction, no significant difference. First non-fatal stroke, no significant difference there at all. But we did see a 49% relative risk reduction, which was significant for all-cause death. And again, these were on small number of events, but just telling us and showing us a signal that there may be benefits because these were, remember, exploratory analysis, secondary events. And that's why we're all very excited to wait for the SOUL trial, which is an oral semaglutide cardiovascular outcome trial in people with type 2 diabetes. And the design is quite simple. Oral semaglutide, 14 milligrams once daily with standard of care compared to placebo standard of care. And this is a double-blind placebo-controlled trial. 9,642 participants have enrolled. And it's quite simple. Basically, people aged over 50 years with established cardiovascular disease or CKD, an HbA1c between 6.5 and 10%. It's an event-driven trial. Duration is up to 5 years with planned 1,225 events. The first patient, first visit was in June 2019. So we're hoping that we will have the results of this trial, which will be quite an exciting time in 2024. So in summary, we've shown you that type 2 diabetes is a progressive disease, but effective treatment of people with type 2 diabetes will require multiple drugs in combination to manage the multiple pathophysiological defects that people have. We've seen that there are a number of barriers to injectable therapies, including fear and adherence, and sometimes these barriers are not so much with patients, but with healthcare professionals. And oral semaglutide, oral GLP-1 receptor agonist, was the first one, has good efficacy for HbA reductions and weight reduction and low rates of adverse events. And what we really need to think about in clinical practice is simplification and look at combinations of therapies with oral therapies as first line, which may offer a good solution for our patients to improve longer term outcomes. Thank you very much for listening.